Okay, let's try this again. So we're going to talk about management of patients with cerebral vascular disorders. And so cerebral vascular disorder is any functional abnormality in the central nervous system that occurs when the blood supply to the brain is disrupted. Stroke is the primary cardiovascular disorder and the fifth leading cause of death in the United States. Stroke is the leading cause of serious long-term disability in the U.S. So while it's the fifth leading cause of death, it's the number one leading cause of long-term disability in the United States. The financial impact of stroke is profound. Because so many patients are now surviving stroke but are disabled, the costs include loss of productivity, financial loss to the patient, and the cost to the healthcare system. All right, so what is agnosia? Is it failure to recognize familiar objects perceived by the senses, the inability to express oneself or to understand language, the inability to perform previously learned purposeful motor acts on a voluntary basis, or impaired ability to coordinate movement, often seen as a staggering gait and postural imbalances? Well, the answer is it's failure to recognize familiar objects perceived by the senses. And there's an explanation of the other things as well. So this is just to emphasize that you really do need to know your glossary terms. All right, so prevention, the best, an ounce of prevention is worth a pound of cure, right? So refer to your chart 67.2. To know how to prevent disease, you have to know the risk factors. There are modifiable and non-modifiable risk factors. Non-modifiable risk factors are age, so older than 55. The older you are, the more at risk you are for having a stroke. Men have more strokes than women, and African Americans are at higher risk. Now, we can't change those risk factors. You can change your gender, but you can't change your sex, so it probably should have said sex there. But other risk factors for stroke that are modifiable is hypertension. That's the primary risk factor for stroke, and probably the primary reason that African Americans are at higher risk for stroke, because they have a higher incidence of uncontrolled hypertension, right? So we can modify that risk factor by controlling our blood pressure, taking our blood pressure medications as ordered, and the other things we do for hypertension. Cardiovascular disease, if you have a history of cardiovascular disease, you're at a higher risk for cerebral vascular disease, because your vasculature goes everywhere, right? So you don't just get vascular disease in your heart or your periphery, you can also get it in your brain. Elevated cholesterol or elevated hematocrit. So cholesterol levels, if you have somebody who comes in with a high cholesterol level, want to educate them the importance of taking their medication, changing their diet, that sort of thing. Obesity, so maintaining a healthy weight will decrease your risk factors for having a stroke. The use of oral contraceptives increases your incidence of stroke because it increases your risk of getting clots, right? Smoking, drug, and alcohol abuse. There's also sleep apnea increases your risk, a few other things. So in prevention, when we have patients who come in before they have any stroke or anything like that, we need to make sure that they know that uncontrolled hypertension could lead to heart attack, stroke, those sort of issues. Elevated cholesterol increases your risk of stroke. Diabetes increases your risk of stroke. I don't think I said that before. With diabetes, you may not be able to reverse somebody's diabetes, but you can have them control their A1C, and an A1C, I believe it's under 6.57, puts you back at the regular risk for stroke, even though you have diabetes. So that's what they mean by modifiable. So is the following true or false? Ischemic stroke accounts for 80 to 85% of strokes, and hemorrhagic accounts for about 15 to 20% of strokes. So this is true. Um, I think it's like 87% of all strokes are ischemic, and about 13% are hemorrhagic. Look, there you go. So stroke is also called brain attack. Not my favorite term, but they started calling it a brain attack in the hopes that we would get better public awareness of what stroke was, because a heart attack is so recognizable. The classic signs of a heart attack. We were hoping to get the public to recognize the signs and symptoms of stroke so they could seek treatment earlier when you have more options for treatment. And we'll discuss what those options are as we move forward. So ischemic stroke is just the disruption of blood supply by an obstruction, usually caused by a thrombus or embolus, that causes infarction of brain tissue, so loss of brain tissue. Now, what's the difference between a thrombus and an embolus? A thrombus is a clot that forms in place. So you may have a narrowing of the artery or a disruption of the arterial wall, and you end up forming a clot in place. An embolus is a clot that occurs somewhere else and travels to the brain. So that could be a DVT, that a piece or the whole thing breaks loose and travels to the brain. Or maybe you have atrial fibrillation. In atrial fibrillation, instead of your atrium squeezing, your ventricle squeezing, your atrium squeezing, your ventricle squeezing, your atrium just kind of sits there and quivers. And because you don't get that good contraction, you can get a clot that forms on the mural wall. And then if you get a good squeeze, it can send it systemically. So there are different types of thrombus here, or embolus. So it can happen in large arteries, small arteries. It could originate, as we talked about, in the heart. So that's your cardiogenic. But they're all treated the same where it happens or where it gets there. We may have some prevention issues, but in the acute phase, it's all treated the same. This slide just, oh, there's my dog. This slide just shows the kind of flow of how infarction of tissue happens. This isn't on the test, but if you like to understand the pathophysiology of it, there it is. So manifestations of stroke, what are the signs and symptoms we see? So that depends on the size and the area affected. So as we think back to our anatomy and physiology lecture that we had on Tuesday, you'll notice that different parts of the brain control different functions, right? We also know that the motor neurons cross, so any damage to the right side of the brain would cause left-sided signs and symptoms. You will see ocular signs and symptoms if it happens in the occipital lobe. If it happens in the Wernicke's or Broca's areas, you'll see speech issues, right? But if you look at all the signs and symptoms, what they have in common is the word sudden onset, right? So this is a sudden onset of numbness or weakness of the face, arms, or hand, usually on one side of the body. A sudden onset of mental status change, altered LOC, confusion, that sort of thing. Sudden trouble speaking or understanding speech. Sudden onset of difficulty in walking, dizziness, or loss of balance or coordination. And the sudden loss of vision, especially in one eye or a visual field. So loss of vision, you may lose your peripheral vision. You can lose it in different quadrants. And when, if you look on the Canvas, in Canvas and 102 under the resources for this section, you'll see that I've posted an NIHSS scale, and you'll see that one of the tests is a visual field test. I also posted a video of them a neurologist going through the full NIHSS scale. I think the video is like 10 minutes. It's worth giving a watch. So where else were we? Sudden onset of severe headache with no known cause. So this is not a headache after trauma or I woke up with a hangover headache. This is just, all of a sudden really severe headache. You can also have perceptual disturbances. You may have depth perception problems, or you see somebody go to walk through a doorway and maybe they hit the door jamb because they thought they had more room. That's also a sign of a stroke. So you can see with the multiple signs and symptoms of stroke why this is not as easily recognized by the general public as like heart attack. That's generally seen as that kind of crushing chest pain. So make sure you know these terms. Again, this goes back to the glossary. You should know the difference between expressive aphasia and receptive aphasia, right? So expressive aphasia is with the difficulty speaking, and receptive aphasia is with difficulty understanding. So TIA is what we used to call a mini stroke. It used to be defined, and apparently your book still does, as a stroke with resolution of symptoms in 24 hours. So the temporary deficit. This is a huge warning of an impending stroke. So if you've had a TIA, your risk of having a stroke soon is actually greatly increased. So if somebody shows up to the hospital with a TIA, it's often worth an inpatient, sometimes outpatient, but a extensive diagnostic workup to determine the potential risk factors, the potential modifiable risk factors to fix, right? So they'll get an EKG to see if they have AFib. They may be sent home on with like a Zio patch or a Holter monitor to see if they're having intermittent atrial fibrillation, because that increases your risk because of that whole clot formation. If they're smokers, they'll be counseled to quit smoking. If they have hypertension, if it's newly diagnosed, they'll need to treat it. If it's long-standing and undertreated or they're non-compliant, this is a good time to talk about patient education, and this is the risk factor for stroke. You've had this TIA, you're at greatly increased risk for having a stroke, and find out why they're not compliant and see if we can get them to adhere to their routine. Are they diabetic and don't know it? Are they diabetic and they are being treated? What's their A1C? Let them know that controlling the A1C can greatly reduce their risk factors for a stroke, so that sort of thing. So the medical management is prevention first, right? So the control of hypertension and other reversible risk factors. So going back to those modifiable risk factors and fixing that. How do we diagnose a stroke? So it's done primarily by signs and symptoms. They come in and do we think they're having a stroke? Then we'll do a CT scan. A CT scan will show if they're having a hemorrhagic stroke. They may do a CT CTA. So a CTA is a CT angiogram. So that's with dye. So they may do that. Remember that if you're doing a CTA, that you need to check for allergies to shellfish, and we need a recent creatinine level because of the nephrotoxic properties of the radiopaque dye. May do lumbar puncture if the CT scan is negative, and that is if they suspect. So treatment for an ischemic stroke is TPA. So this is a fibrinolytic. So it's a breaks up clots, keeps you from forming clots. If they suspect that you've had what's the word I'm looking for here? Subarachnoid hemorrhage, then they may do a lumbar puncture, and what they're looking for in that is blood. So you'll see blood in the cerebral spinal fluid. But if you're suspecting that this is a stroke and not a subarachnoid hemorrhage, and you're within the window, you don't want to do the lumbar puncture because then you're ruled out for getting the TPA. So that's kind of the little caveat on the lumbar puncture. Care outside the window, we'll talk about it inside the window. So if the patient arrives after 4.5 to 5 hours at a non, so we'll just leave it out of 5 hours. Care is primarily supportive, physical therapy, bed rest, oxygen therapy if needed, uh, treatment of vasospasms if they're having any vasospasms. Uh, we want to treat any increased inner cerebral pressure with proper body positioning. We talked quite a bit about that last time. Treatment of hypertension. If it is a non-hemorrhagic, so this is an ischemic stroke, and they're not getting TPA, we allow permissive hypertension in the acute phase to increase perfusion. But that's I think you're working on CPG's clinical practice guidelines in your other courses, and you'll see that. So there is a potential for seizures, and we want to make sure that we prevent any further bleeding if this is a hemorrhagic stroke. Right. So secondary prevention, we want to make sure that the health is we have health maintenance measures, including the healthy lifestyle, not smoking, exercise, eating low cholesterol, low sodium diet, maintaining a healthy weight, and addressing all those modifiable risk factors. One of the things they may do in a workup is a carotid ultrasound. So they'll look at the carotid the blood flow through the carotids using an ultrasound. If they find a significant blockage, they may end up doing a carotid endarterectomy. It's where they go in and make an incision through the neck, open up the carotid artery, remove the clot, sew you back up. These patients, at least locally, are cared for in the ICU setting post-op because you can have some pretty wild fluctuations in their blood pressure. Oftentimes they come out, usually they will, come out with a arterial line for continuous blood pressure monitoring because they can have wide fluctuations because you've messed kind of with those baroreceptors that help control blood pressure. That does equalize over time. Anticoagulation therapy for atrial fibrillation, we talked about that and how they can form clots on the mural wall. So patients found to be in atrial fibrillation to reduce the risk for stroke often take a blood thinner, usually Coumadin, that requires regular testing to make sure it's within the therapeutic window. And there are newer anticoagulant medications out there that do not require testing, but they're significantly more expensive. Patient may be on antiplatelet therapy. This is similar to people with risk factors for an MI. So they may be on an aspirin, potentially, maybe they're started on Plavix, something like that. They will be given some sort of cholesterol medication. Statins are the preferred medication. Lipitor is the preferred drug. If they need to be on drugs, you always want to try diet therapy first, but if that doesn't work, be put on a statin. And maintenance of hypertension, so we may have to put them on some sort of antihypertensive medication and monitor them for compliance. This probably should have been first since that's the #1 risk factor, but there you go. So this is kind of what your carotid endarterectomy surgery looks like. You can see they're going and pulling out that clot. So the medical management in the acute phase of stroke, so this all depends on how early the patient arrives in the emergency department after the first onset of symptoms. Prompt diagnosis and treatment is very important. Refer to table 67.4 in your book. The assessment tool used to assess stroke is the NIHSS tool. Go away. Sorry about that. So the NIHSS assessment tool is a standardized tool that allows us to assess for stroke scores that are consistent across care areas. And you'll see the full assessment again is in your Canvas modules. So for patients who arrive between the 3 and 4.5, between the before 3 hours or between 3 and 4.5 hours with additional exclusion criteria, may be treated with TPA. So TPA is the only FDA approved thrombolytic drug for the treatment of acute ischemic stroke. It's also approved for treatment for PE and MI, but it's not used as often for MI because of it's a much higher dose. I don't know why. And higher bleed rates, right? So it's an IV dose and administration. It requires close monitoring, status post-administration of TPA. It requires monitoring after you give TPA. You'll want to monitor them Q15 minutes for 2 hours, Q30 minutes for 4 hours, and every hour for the remainder of the 24 hours. After 24 hours after administration, the risk of bleed is really back to normal. And you're doing, when we say monitor them, you'll need to do vital signs and a focused neuro assessment, not a full NIHSS scale, but a focused neuro assessment that includes level of consciousness, ability to respond to commands, arm and motor strength, and then any thing that they presented with speech or with any aphasia issues. You want to assess that as well, and that may monitor from site to site, but the frequency of the monitoring is standard with TPA. You also want to make sure that you're taking their temperature every 4 hours, because an increase in temperature greatly increases the metabolic demand in the brain at a time when there's already decreased supply. So make sure you monitor that. You want to elevate the head of the bed 30 degrees unless it's contraindicated. Maintain airway and ventilation. Stroke patients are at high risk for aspiration. One of the major complications, or the most frequent complication status post-stroke, is aspiration pneumonia. So all stroke patients are MPO, nothing by mouth, until they've passed a swallow eval, or swallow screen rather. If they fail the swallow screen, then they'll get a full swallow eval and recommendations from a speech pathologist. Yeah. So hemorrhagic stroke, this is caused by bleeding into the brain or other spaces, whether it be the ventricles or subarachnoid space. It may be caused by spontaneous rupture of small vessels. That's primarily related to hypertension. Subarachnoid hemorrhage can be caused by a ruptured aneurysm or intercerebral hemorrhage related to arterial venous malformations or intracranial aneurysms, or medications such as anticoagulants can put you at a higher risk for brain bleed. And remember, these are non-traumatic bleeds. If you're on a blood thinner and you fall and hit your head and you bleed into your brain, while it's treated the same, it's actually classified different. It's classified as a trauma rather than a stroke. Signs and symptoms of the same, treatment are the same, but it's classified differently. So manifestations of a hemorrhagic stroke are similar to an ischemic stroke, depends on the size and location of the bleed. Severe headache would get me more towards thinking that it was hemorrhagic. Early and sudden changes in level of consciousness. You may have vomiting. This is, again, secondary to the increase in intracranial pressure. And of course, bleeding, we usually don't see that, but you may see it if it was related to anticoagulants. But so patients recovering from ischemic stroke, so their assessment, so in the acute phase, we talked about how often you would do vital signs and assessments for patient receiving TPA. Other than that, it will be as ordered. So if they don't receive TPA, so it could be every 4 hours or so. It depends on the ordering physician, right? So you want to do ongoing, frequent monitoring of all systems, including vital signs and neurological assessment, uh, altered level of consciousness, motor symptoms. So looking at their signs and symptoms of stroke. The initial assessment, each shift of a stroke patient, whether the acute or non-acute phase, should always be the NIHSS scale. And then you can do a focused neuro assessment that focuses on the deficits that they came in with for the assessments between your initial assessments each shift. So you want to monitor their INO, blood pressure, monitor for any bleeding, and make sure they maintain a good oxygen saturation as part of their vital signs, right? So in the post-acute phase, we want to monitor the mental status, sensation, motor, their swallowing ability. Even once swallowing is determined, we want to continue to monitor them for any signs that they're having any trouble with swallowing. We want to monitor their nutrition and hydration status and maintain them at a good, well hydrated but not overly hydrated and sufficient nutrition to meet their metabolic demands. Skin integrity can be a big issue. If you have a patient who has a stroke and has some sensory deficits from their stroke and or flaccidity, they may not notice, feel to turn, go through your Braden scale. So these patients may need turned every 2 hours. They may have issues with contractures, or so keeping the body in alignment. You can use splints. Make sure if you're using splints or rolls that you remove them every 2 hours and assess underneath, so because you get skin breakdown at the splinted areas. You may need to be particularly aware of stroke patients and their shoulders, so you may need to place a pillow under the axilla to keep them, is it abducting? Anyway, to keep that shoulder in place. Sometimes they'll use a sling when sitting up so that it doesn't hang. You want to make sure to never lift a patient by the flaccid side. So if you're trying to assist somebody up, don't assist them up on the flaccid side. You could really damage their shoulder. Want to make sure we assist them with performance of the ADLs and use the proper assistive devices necessary for them to perform as much of their ADLs as possible. If they have bowel or bladder issues, we'll need to put them on a bowel and bladder training program. We don't like anybody in the hospital to ever get constipated, but especially heart attack and stroke patients. So they'll probably be on some sort of stool softener, at least in the acute phase during the hospital, and encourage high fiber diets outside of the hospital. So here are some potential diagnoses for stroke. Make sure that it's related to your patient. Don't forget this one here, your impaired verbal communication. We need to be able to communicate with our patient as much as possible. If they have problems with speech or understanding, sometimes they can still write or use a communication board where they can point to, it'll have pictures of, I need to go to the bathroom, I want to sit in the chair, different ones. I'll see if I can find one and post, find an image of a stroke communication board and post it to Canvas. So obviously they have decreased cerebral blood flow, an inadequate delivery of oxygen to the brain, but pneumonia, again, as I told you, is the #1 potential complication for stroke patients. So make sure we're doing the aspiration precautions, elevating the head of the bed 30 degrees, nothing by mouth until they've passed a swallow screen or evaluation. And suction by the bed if they're able to suction themselves, frequent suctioning if they cannot, if they can't handle their own oral secretions. Goals, again, will be think back to what your diagnosis is and have the appropriate goal. Make sure that your goal is realistic and measurable, right? So interventions we need to be sure that they focus on the whole person, provide rather interventions that prevent complications and promote rehabilitation. We should always be collaborating with the physical therapist and see what sort of exercises or um, uh, adaptive equipment they're using, and make sure that we're reinforcing that with the patient when physical therapy is not there. Provide support and encouragement, really listen to the patient, and see their needs, and be patient, especially with patients who have difficulty communicating. It can be a great win for them to finish a sentence, to find that word, to get that thought out. And sometimes we want to be helpful and we finish their sentences, and we're really kind of taking that win away from them. I had never thought about that until I attended a stroke support group when I was the stroke coordinator at Ukiah. And one of the patients had told me that that was one of the things he found most frustrating. And I was like, oh my God, I do that. So just be aware. So improving mobility and preventing joint deformities. So again, not only for skin integrity, but also for joint health. Want to turn in position and correct alignment every 2 hours. We can use splints to help prevent contractures. I talked about that, but remember, if we're splinting, we need to assess underneath there and relieve pressure every 2 hours as well, right? Passive or active range of motion 4 or 5 times a day. Active range of motion is just where you have your patient do the full, range of motion, and often they'll start at the hands, wrists, elbows, shoulders, get them all going so you keep everything good and lubricated. Active is when they can do it themselves. Passive, obviously, if they're flaccid on one side, they can't do that, so you need to provide the range of motion, right? Prevent, see, it is abduction. Shoulder abduction, you can place the pillow under the axilla, kind of keeping it away and having good alignment there, right? Don't lift by the flaccid shoulder. I knew it was on here somewhere. I guess I could have waited for that. And so those are kind of measures to prevent shoulder problems. Want to encourage the patient to exercise the unaffected side, so that is the active range of motion. Establish a regular exercise routine, and assist patient out of bed as soon as possible, unless of course they receive TPA, then they're on bed rest for 24 hours. And assess and help patients achieve balance. Make sure that you move slowly. Have 2 people if you need to. Most places will do oh God, no, I can't think of it. Their MAP score. They'll do a score and make sure you have a good ambulation belt, and they'll do ambulation training. Physical therapy is great for this, and make sure that you're collaborating and reinforcing their education. So we need to enhance self goals, encourage personal hygiene, use adaptive equipment. If they can't make a full grip, you can get toothbrushes, spoons, all kinds of things with the built up handles if they can't make a grip to grip a full toothbrush. Use strategies to enhance communication, whether that be the communication board, paper and pencil, some sort of gesture or sign language to figure out. Keep your communication simple until you can get a good rapport going, right? With some stroke patients, they may have what they kind of ignore one side of the body. So if you have a patient who does that and kind of has a deviated gaze and is always looking one way and kind of pretend the other way isn't here, when you're delivering important information and teaching moments, you always want to do that to the unaffected side, so that where they're normally looking. But for everything else, you want to try and get that patient to realize that it's your body's still over there, there's still a world over here, so that they may turn to talk to you. So all other communication will happen on the affected side to get them to start training themselves to realize that that's over there. So For nutrition, speech therapy, again, we've talked multiple times about that and the risk for aspirations. They will determine, for anybody who failed the swallow screen, they'll determine the viscosity of fluids that they need, the consistency of the food that they need. If they need a pureed diet, thickened liquids, that'll come from them. Nutritional therapy, a dietitian is often consulted on stroke patients to make sure that they're receiving adequate nutrition, especially if they're having swallowing difficulties. So we want to make sure that they're getting adequate calories to meet their needs, right? When we feed stroke patients who are allowed to eat, they need to be sitting up at a 90-degree angle, preferably out of bed. Preferably we get them to a chair to eat. If they do have some issues with swallowing, one technique that they can do is tuck the chin to help them swallow. We always want to kind of throw our head back. That's actually the worst. It kind of creates a direct pipeline to your lungs. So you want to tip your head down and swallow. Your speech pathologist will have several exercises for them to do and certain tricks and of the trade to get them to be able to swallow better. Always consult, collaborate with them, and reinforce their education. We talked about bowel and bladder control and training, high fiber fluids, toileting schedule, that sort of stuff. So nursing process with a hemorrhagic stroke, the assessment is the same as it is for a ischemic stroke, just a different cause, right? But we are a little more concerned about headaches. So complete and ongoing neuro assessment, altered level consciousness, pupillary reactions, note any neuro deficits, whether they be cranial nerves or any of those in your assessment, right? So some potential diagnosis. I don't like either of these. This is what your book says. If they had a stroke, they have ineffective cerebral tissue perfusion. And there's really not, well, with the vasospasms, there's some collaborative stuff. We could do some dependent stuff, rather, the medications we can give. Independently, I suppose you could keep them in body alignment. But these aren't the best nursing diagnoses. They would be, our best nursing diagnosis would be better related to the nursing care we give, whether that's preventing skin breakdown, falls risk, risk for impaired nutrition or imbalanced nutrition, that sort of stuff. Risk factors are huge diagnosis for stroke. Actual diagnosis: impaired communication, ineffective family coping. So it all depends on the patient. So these are some collective problems you may see with a hemorrhagic stroke. Some potential complications: continued vasospasms, seizures, hydrocephalus, rebleeding, if you get the bleeding to stop and then it rebleeds. Hyponatremia, does anybody know what that's related to? Remember the structures in your head and what caused it? I had something in here that's really nice. It's an activity. Did I put it in here? Oh, I did. That you're going to work on. So what is what causes hyponatremia? That'd be your SIADH. And that's for because of damage to the hypothalamus or pituitary gland during a stroke. Sorry, I defined that. I want to make sure I got it right. So the goals may include improved cerebral tissue perfusion. Again, I don't like that. Relief of anxiety. The absence of complications is the best one I like. Another, also, this patient, if you have a stroke patient, healthcare knowledge deficit is a good actual diagnosis. You're going to be doing continuous teaching with this patient, so that's always a good diagnosis, related to new disease process, that sort of thing. Where was I? there. Oh, aneurysm precautions. So if you have somebody who has a leaking aneurysm or known aneurysm, you want to decrease any, you want to have a non-stimulating environment. You want to prevent increased inner cerebral pressure, so keeping good body alignment. Uh, Absolute bed rest with the head of the bed 30 degrees or less. Avoid all activity that may increase ICP. Valsalva maneuvers. So again, we go back to the stool softener. Acute flexion or rotation of the neck, right? So you don't want the patient in bed with so many pillows that their head's like this or laying to the side like this. You want everything in a nice anatomical alignment. Um, you want a non-stressful environment, dim lights, avoid reading. They say no TV or radio, but sometimes that can increase their stress. So, and visitor restricted, again, that depends on, sometimes the visitors can really help calm the environment. So use your judgment. Um, Patient education, talked about that, support and reinsurance. Seizure precautions, especially in hemorrhagic stroke and patients who receive PPA. You want to make sure that you initiate seizure precautions and strategies to gain and promote self-care and rehabilitation. It's a lot of collaboration with physical and occupational therapy and reinforcing their teaching. So home care and education for patients recovering from stroke. Need to refer back to chart 67.6. We want prevention of subsequent strokes. So this is related to individualized education about their modifiable risk factors and how addressing those can decrease their risk for future stroke. It's a mandatory stroke education. Um, what are the signs and symptoms of a stroke, how to activate the 911 system. If they're started on any medications, we need to make sure that they get education to each medication they're taking, why they're taking it, how it helps reduce their risk factor for stroke, that sort of thing. They need to be educated about their follow-up visits, physical therapy, adaptive strategies to use assistive devices for their ADLs. So, are they going to need a walker? Do they have a splint? Are they now in a wheelchair? That sort of stuff. Activities to do. They should also be educated about potential support groups, community resources. This strokes can vastly change the family dynamic. So we need to make sure that we're educating, as with any other disease, but especially strokes, to the patient and family as well. Because there are so much to learn and so many things to do and so many more appointments to be going to, case management should be consulted on really almost every stroke patient that walks through there. I'd say everyone case management should take a peek at. They may be more knowledgeable about the potential community resources and financial help that can be out there for the patient. All right, so what are expected potential outcomes for a patient recovering from a hemorrhagic stroke? So this is expected patient outcomes. The exhibits absence of vasospasms, has residual aphasia, 1 to 4 seizures, or complains of visual changes. So the answer is A, expected outcomes for a patient recovering from hemorrhagic strokes include the absence of vasospasms, no seizures, normal speech patterns, and no visual changes. And again, that depends on how they came in. But so what prevention would be included in aspiration precautions for a patient in the acute phase of stroke? Which would not be, see, you always got to read them closely, would not be included in aspiration precautions. So it's we would not elevate the head of the bed 30 degrees. Remember, it's 90 degrees, right? Um, so the interventions to prevent aspiration include referral to speech therapy for swallowing evaluation, having the patient chuck the chin to the chest when swallowing to that helps close off the trachea. Preventing aspiration into the lungs by providing thickened liquids or a pureed diet may be necessary. Sitting the patient at a full 90-degree angles, not 30-degree angles. All right, that is that. Let's see if this works. Wish me luck, people.